In this video film, modified surgical technique for laminar macular holes with laminar hole associated epiretinal proliferation has been described. Laminar macular holes were first described by gas arising from an abortive process of full thickness macular hole formation. VMTS study group defined OCT characteristics of LMH to be having foveal thinning with irregular contour, breaks in the inner layers of the fovea, intraretinal split, and an absence of full thickness foveal defect. Recently, Govito et al. Classified laminar macular holes into tractional and degenerative varieties. Degenerative LMH are associated with an atypical ERM or LHEP, which are thicker, non-tractional, and arises from inner retinal layers, and such holes have poorer visual acuity, large hole diameter, round edge cavitation, and higher incidences of ellipsoid zone disruption. Whereas tractional LMH are associated with conventional or typical ERM, and such holes have intraretinal split with schisis-like cavitations and generally have intact ellipsoid zone. Here are a few examples of tractional LMH in our setting showing intraretinal split, thin conventional ERM, and schisis-like cavitation with intact ellipsoid zone. Few examples of degenerative laminar macular holes showing thick LHEP with round edged cavitation and disrupted ellipsoid zone and ELM, and sometimes they may have intact ellipsoid zone and ELM as well. If we look at the outcomes of conventional surgical technique of double membrane peeling, we can see here in this meta-analysis, in the earlier series, visual acuity improvement was significant in both types of ERM, whereas in the later series, the vision did not improve, particularly in cases of LMH with atypical ERM. Again, looking at the major complication of full thickness macular hole formation with the surgery, it was present in cases of atypical ERM mainly. Thus, for tractional laminar macular holes with conventional ERM, double membrane peeling should be the preferred approach, whereas for degenerative laminar macular holes with atypical ERM, double peel does not improve visual acuity, and in cases it may lead to formation of full thickness macular hole. So there was a need for an alternative technique which in the form of LHEP embedding only was first described by Shiraga et al. And later they followed up with a modification of superior ILM inversion along with LHEP embedding. As we can see here that the LHEP was embedded along with a flap of superior ILM. And later Prisna et al. Coined this technique as double inverted flap of ILM and ERM for degenerative laminar macular holes with LHEP in their series. This video demonstrates surgical steps of embedding technique for degenerative laminar macular holes. Following injection of BPG dye, LHEP gets marked out distinctly from surrounding stained ILM. In some cases, they can be identified as thick yellowish tissue around the LMH defect. Raising the flap of LHEP is challenging as it's thick, gummy, sticky and tightly adherent to underlying retina. Therefore, the patience is the key here with utmost care taken to make a wall of LHEP flaps around laminar macular hole. BPG staining of underlying ILM around LMH is redone and ILM flaps are made around LHEP flaps to cover them. The basic principle of this technique is to embed the Muller cell-rich LHEP tissue back into the lamella macula hole defect, as the origin of LHEP is from the inner retina, and thus the Muller cells produce growth and trophic factors to close the defect. We can see in this case a good recovery of foveal contour and functional outcome happened. The second part of video describes the use of embedding technique in a case of lamella macula hole with LHEP in retinal vein occlusion. There are no reports on surgical intervention for lamella macula hole in retinal vein occlusion. The surgical steps are similar to that used for degenerative lamella macula holes. In retinal vein occlusion, underlying retinal ischemia with poor state of photoreceptors due to chronic CME leading to lamella macula hole portends a challenge for a good surgical outcome. Again, the rationale behind embedding lies in the origin of LHEP from inner retina, comprising of Muller cells and glial cells, which in turn produces trophic and growth factors for healing and thereby helps in closing the defect. Hence, we can see here a successful anatomical and functional outcome using embedding technique for LMH in association with retinal vein occlusion. Using the shown modification of 360-degree ILM inversion with LHEP embedding, recently we published a case series that showed 80% of the degenerative lamella macula holes to recover with good anatomical and functional success and without any incidence of full thickness macula hole formation.